Good morning, everybody. For anybody that doesn't know me yet, I'm Antonio, one of our fours. Um, and I'm just going to go ahead and get started with a little story that kind of illustrates a lot of the points I want to make today. So, um, maybe last year, I was in the downstate fast track, having a pretty normal day. When a patient popped up on the board with the chief complaint of sexual assault. This patient was a young trans man with dissociative identity disorder that had come with a recent sexual assault. Um, my first feeling was, I don't know if we can, this sounds a bit complicated. I don't know if we should, if Fast Track can handle this. Perhaps we should upgrade this patient to the main, maybe needs a psych consult and more resources, etc. Um, Beyond that, what I think I really recognized was um, a feeling that I wasn't necessarily comfortable or ready to appropriately treat this patient. Um, and upgrading out of my zone may have gotten there. But I took a moment to slow down and kind of check myself and where that was coming from, and identified that it was a whole lot of just me assuming things from looking at a chart that there's going to be complex psychiatric things going on. Um, and I already am not super comfortable with like doing a forensic exam myself in this case. Um, However, after I stopped assuming how the encounter was about to go, I simply got up and took a moment, remembered my prior education I've had in trauma-informed care, checked my biases for a moment, and I just went and saw the patient. So today, wait 1 second. Now I'm lost. There we go. Today, we are going to talk about trauma-informed care in the ED, and we're going to kind of walk through some key components of that encounter that I had. Hopefully, they can illustrate a lot of the key principles and learning points off of incorporating trauma-informed care into the ED. So I just want to thank the social EM team, especially Dr. Arcache and Dr. Sklar, for all their very valuable feedback and help getting this presentation together. And a few goals by the end of the talk will be to understand the core principles of trauma-informed care, identifying the importance of incorporating trauma-informed care into the clinical practice as a universal precaution for all patients in the acute care setting. Consider gaining best practices, strategies, and some language to use based on these principles. Recognize barriers to implementing these principles and imagining both immediate and more permanent structural organizational solutions to these barriers. So, um, getting a little bit more boring, just going to definitions, I do find the general definition of trauma itself to be helpful by the Substance Abuse and Mental Health Services Administration. Um, this states that individual trauma results from an event or a series of events or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, as lasting adverse effects on the individual's functioning, mental, physical, social, emotional, or spiritual well-being. You can kind of focus on these three E's. So there's some sort of event or cascading events or continued events. There's an experience of those events, and then they have lasting effects um, that are deleterious in various components of life. Now, personally, I don't find a very like strict definition of trauma to be particularly useful or beneficial to kind of get into the weeds of what may or may not be trauma. But kind of using this as a starting point to open up um, considerations for real breadth, depth of understanding how trauma can compound is at multiple levels, the individual and societal level. So we can expand to a concept of like an ecological model of trauma. I used this figure here um, that honestly I find the structure of it a bit interesting, but it kind of just illustrates that there's from the individual onto basically interpersonal being between multiple people, collective being a group, and then structurals including policies, material realities, et cetera, that influence all these things. And then kind of around the circle, we just have honestly just various examples of um, things that can influence uh, trauma. So there's a bunch of different levels of trauma. There's impersonal trauma. These are things that may come from ecological events like natural disasters, hurricanes, tsunamis, etc. Then interpersonal traumas are events that happen between people. These are probably what you may first think when it comes to like child abuse, neglect, intimate partner violence, sexual assault, human trafficking, things like that. And then kind of expand to community violence and collective trauma that involves the exposure to intentional acts of interpersonal violence that's in public areas where individuals who aren't immediately related um, experience the trauma, whether it be from gang violence, public shootings, war, segregation, collective punishment. And then there's further kind of a concept of historical trauma, which refers to the complex and collective trauma that's experienced over time across generations by a group of people that may share some sort of identity, affiliation, circumstances. And this can refer to things like colonization, apartheid, genocide, enslavement. Um, and historical trauma may kind of give uh, a concept of this kind of lies in the past, but as we know, the sequela of things like imperialism have lasting sequela in the material realities of people and especially their health outcomes. Um, so unfortunately, as kind of all of us know from just working even one shift in the ER, unfortunately, trauma is quite ubiquitous all around us. This is both kind of, I mean, my own anecdotal experience, but there's a fair number of studies that show a very wide prevalence of trauma pretty much throughout the world for everybody. There's a WHO study that showed a large survey of 24 different nations. The global prevalence of exposure to one or more traumatic experiences is about 70.4%. The majority of those having multiple traumatic exposures. You've likely also heard of adverse childhood experiences or ACEs, which are various exposures like neglect, abuse, household dysfunction, substance use in the home, um, etc. And unfortunately, these are very common even just in the US, with over 60% of US adults reporting adverse childhood events in their years. So these events create cascading sequela. And here in the ER, we deal with certainly the immediate aftermath of traumas, whether they be various forms of assaults, just illness, whatever it may be, kind of the immediate acute effects of trauma. But we also deal with the long-term sequelae of trauma, whether it be how patients react to the ER experience, whether it be chronic health conditions that have been exacerbated and influenced by prior traumas and patients' relationships to them. Um, there's also good data that shows essentially those with significant histories of trauma interact with emergency and same-day services um, to a more significant degree than those with none or less traumas, and simultaneously show decreased utilization of primary and mental health services, something that we do see here in our ERs very consistently. Um, and then all of these components, whether it be different types of trauma, um, and our responses to them, especially in the medical realm, medical trauma itself, whether it be from just experiencing being in the ER for a few hours or near-death experiences, etc. Medical trauma can compound the effects of other traumas for folks. Um, and themes of like loss of autonomy, fear of significant harm, can re-traumatize patients, which makes it more difficult for them to heal, for us to understand what's going on, for us to interact with them and create therapeutic relationships with them. So, what do we do with all of this? So, trauma-informed care is a principle actually made by the um, SAM HSA that define that gave us our definition of or working definition of trauma earlier, and this kind of came around in 2014 as a kind of operationalized approach to treating patients more effectively. That with an understanding that most patients have trauma, and this significantly affects the way that they interact with the healthcare system, and for us to understand that. Um, and change some of our consistent practices and learn more best practices, we can more effectively um, heal these patients. So the trauma-informed care paradigm focuses on six key principles, and you can read them there on your screen. But trustworthiness and transparency, such as just defining your roles, uh, letting patients know what is going on, being upfront, honest, basic stuff like that. Um, Peer support and mutual self-help, gaining, leveraging community resources, um, and an entire like team and village of folks to support folks that are dealing with trauma. Collaboration and mutuality. It's a little bit different from peer support. It's kind of more from our end that we are making decisions with the patients and with their choices, their wishes, their goals of care in mind, in discussion with them. And then we can honestly move on to the more meat of these things. But safety is, of course, important. And then the one component that I find to be I'm glad that they added or they incorporated in here is understanding cultural, historical, gender issues that influence all of these things, whether it be um, questions of like racism, homophobia, transphobia. These things all influence the way that patients interact with us and navigate their traumas, whether it be with us or in the community. Um, you'll see a lot of the points in this talk is we seem to like to do a lot of the same gets an alliteration in. We had the three E's with the definition of trauma. We got the four R's of trauma-informed care, which is realizing the widespread impact of trauma and understand paths for recovery, recognizing the signs and symptoms of trauma, um, responding by integrating that knowledge and understanding into our individual actions, as well as policies, procedures, practices, the structures that we build around us, and then doing all we can to resist re-traumatization. And that's kind of the point that I think we can step in with just our individual interactions in the ER, which is where I'm headed to focus on in the rest of my short time here. Um, Dr. Arcachea hit me with a really great quote when he was giving me some feedback of this. I'm pretty sure this is his quote. I couldn't find it anywhere. So, but if you find this to be a quote from somewhere else, no, you didn't. But trauma-informed care is both a clinical mindset, but also an organizational and structural practice that reshapes how we design or dream about and deliver good quality care. So, as we like to consider at least some solid evidence basis for the practices that we do. As with many kind of more soft skills, qualitative questions, research is a bit trickier, funding harder to come by. But and especially specifically in the emergency department context, um, research is kind of just starting to burgeon more on the applications of trauma-informed care in the ED, and both quant and qualitative research. There's a lot more data in things like outpatient mental health care, pediatrics, primary care, things like that. But there's some promising studies that I saw a few that suggested that incorporating these practices reduces the number of patients that end up in restraints and their overall time in restraints, both in both the ED and inpatient um, contexts. And there's promising evidence for just improving outcomes for patients that have experienced sexual assault and significant adverse childhood events. Um, but it certainly requires further inquiry. Um, and while I am focusing on trauma-informed care, and it does have broad applications across many contexts, it certainly is a limited and only one solution for addressing, individual issues and questions of trauma in the ED. Um, but it does synergize well with ideas of health equity, racial justice initiatives, et cetera. So last part of the talk is we're gonna kind of similar to the last talk I give, go through a little toolkit of best practices, language to use to more effectively take care of patients that have significant trauma. Um, this is something that I tell myself very often, and I think it kind of undergirds everything that we're talking about here. The rest of the talk, that basically the entire clinical counter is an ongoing negotiation of consent. Each exam maneuver we do, each even question we ask, is a negotiation of consent to the degree of which a patient will tell us all what's going on in their lives, will allow us to examine them, how they would like that to happen. All those things in every patient encounter. This is true, and whether it be about something as simple as a stub toe all the way to very significant traumatic experiences. So let's get together a little toolkit. I'm going to go back to um, my patient encounter to kind of run through some of these best practices. So remember going up to the patient. I'm going to leave some of these points on the slides while I talk about that case. But um, so I finally went up to talk to the patient. Um, the patient was there with his caseworker that had known him for a long time. I introduced myself and explained my role. Um, I initially asked the patient what name he was using at the time and what pronouns he uses. I asked for the caseworker to step away for a moment to speak with the patient alone, get the actual interview alone, and to clarify the degree to which he would like his caseworker knowledgeable about the details of what's going on, if he wants him to know anything, to which he said he would like the caseworker basically fully involved to know everything that's going on. Um, and then I also asked the patient if it was okay if I spoke with the caseworker alone briefly for a few minutes. Said that was fine. In that time, I clarified the nature of the patient's dissociative identity disorder, the various identities that are documented in the chart, how to know whether this patient, like what identity they were occupying at the time, and very uh, various like body language tells that the caseworker was explaining to me that you can kind of notice when the patient shifts into a different identity at the time. And we discussed that if that were to happen kind of in the middle of the forensic exam or what have you, that it may not be the best idea to continue pursuing that at the time. But given the patient was at his baseline, kind of his most common identity, um, and had been consistently so since the event. And the patient was very well oriented and cooperative, and so we decided it was we should definitely continue with the forensic exam as the patient had wanted to do. Um, the last part of kind of opening the encounter that I appreciate is basically preparing the patients for exactly what's about to happen, whether it be going to be examinations, um, or what have you. Um, Me being uncomfortable with at the time of doing the forensic exam, I prepared beforehand, before I kind of like had this full conversation with them about, what the next steps were, confirming with a bunch of folks how, multiple procedures, how the chain of evidence needed to work. Um, and then, yeah, I got to work. I explained the patient's rights, continued to remind them that um, we are going to do as much as they feel comfortable doing today. Um, and we continued to do the forensic exam. Now, for interview, I'll pause off of that example for just a moment because within the interview itself, I don't remember a lot of what we were the details of what we were talking about, but some basic best practices, of course, using language interpreters, which I would hope we all consistently do. It can be easy to rely on family, but especially in cases of trauma, you don't know um, the underlying relationships of patients, the degree to which they want their information shared. Um, you don't know if a patient's family is going to correctly tell you about what's going on, et cetera, et cetera. And avoiding stigmatizing language, things like, difficult patient, non-compliant, drug seeking, of course, any slurs, things like that, especially in front of the patients or in front of other patients, things like, um, it's just not really a good look, is all I gotta say. Um, but and then kind of reviewing at the end of each part to clarify with the patient, does this sound right? This is what I'm hearing. This is what I've understood to be the case. Does that sound right? Do you want to clarify anything or correct anything or add anything? Which goes back to our one of our principles of supporting the patient's autonomy through all of this. The last, the physical exam and procedures part, I think is some of the most important. In this case with this patient, we did the forensic exam. I did not do um, like a detailed pelvic exam or anything like that. But within the pelvic, like doing sensitive exams, specifically, pelvic exams, rectal exams, breast exams. Um, I kind of have a script, and I'm sure many of us have developed scripts over time, but especially for the juniors and those that haven't had as much experience with those, I kind of wanted to share my typical approach when doing sensitive exams and kind of the script that I use. Um, so I always start with the reason this is indicated. Um, because you are sharing with me these symptoms, lower abdominal pain, what have you. The next part of my evaluation is a pelvic exam. I'll often say like an exam at the OBGYN. I'll ask if they've had one before or had one in a long time. If they don't, I'll kind of remind them how it usually goes. If they have, I'll remind them that I'm not doing a pap smear, so it shouldn't be like painful in that way. Um, and then I ask, this will help me make a diagnosis. Is this okay with you? Of course, if they say yes, we're going to prepare the patient in as much dignified, private way as possible. Um, get them gowns, and but specifically, I guess going kind of back to the patient that I used, that we were, or the patient story that I've been talking about. Clarifying what words I clarified what words the patient used for his genitals. I actually don't know if I said at the beginning this was at least in his kind of primary identity, was a trans man. So I asked, how do you refer to your genitals? It's kind of as simple as that. And he told me the words that he uses, and we used them, and that was just it. Um, After kind of setting up, I'll say there's going to be two parts of the exam. First, I'll gently insert my fingers and press on the cervix or whatever kind of words would be appropriate for this patient. But I'll use specific language for what I'm doing. I'm going to check your cervix, your ovaries, check for any tenderness. That's going to help me see if you have infections or what have you. Um, the second part of the exam will be with the speculum, where I'm gonna take a look to see if you have any bleeding, et cetera, at any point, and then giving them an out at any point for any reason. Say every time, if at any point you would like me to stop, please say stop, and we will stop. Always give a, do you have any questions? Or what questions do you have more specifically, assuming that there are questions? And then asking, can we do anything else to make this more comfortable experience before then? Um, Kind of a side note for all of this, that we get, you should do these exams with a chaperone, especially if, um, like an all-male provider team getting a female chaperone for sensitive exams. But a point I want to kind of drive home is we make everybody safe. We keep everybody safe. Just being a male provider and having a female chaperone doesn't necessarily mean that this is now a safe encounter. Uh, Gender notwithstanding, we all have a responsibility to keep ourselves and our patients safe. So, for example, I've had an experience where a chaperone kind of uh, moved a patient's leg to kind of um, open their legs further, told them relax, and I kind of had to like pull that back and correct them at that time because those are kind of phrases you want to avoid in these kind of exams. So things to always be mindful of is basically if you can imagine this being innuendo in any sort of sense, if this can reference to anything sexual at all, don't use it. Um, so this is like illustrated in using instead of the bed, the sheet, the stirrups, using footrests, the table, the drape. Um, Never do say like do this for me, open your mouth for me, do this for me, what have you. Just request, please, and then just plainly describe the action that you're asking. Move your arm forward, move your leg to the side, um, and then specifically like I always use the verbiage of allow your knees to fall to the side rather than anything like spread your legs, not using any force, not using the palms of my hands to touch, using the backs of my hands very gently. Um, and then using things like healthy rather than normal. Um, Very briefly, kind of closing the visit, reviewing all these things with the patient, reminding them of further options, using shared decision making in their disposition process, the degree to which they want other parties involved, sharing with them resources, whether it be Kavi here, NYC, and like city resources, um, here at county resources, et cetera, providing what they would, what a patient would accept, and if not, then just allow offering is the best we can do. And then lastly, using a teach back method that is not patronizing in a way of like, let me see if you were listening, but just like, hey, this was a lot today. We talked about a lot. I just want to make sure that we're on the same page. Can you just explain to me what your takeaways from this encounter were essentially? Um, I'm pretty much out of time. I'm also pretty much done. The ER makes doing all of this really hard. There's not a lot of space, there's not a lot of privacy, there's not a lot of time. It's all crazy in there all the time. But Do your best in your individual efforts to move patients, get them in more private rooms, interview them more privately, not in the hallway. Um, and just try to create as many environments to have um, a good encounter as possible. But then that goes above, if all of that is so hard, to try to create structures within our ERs and our hospital systems that are more amenable to easily giving people privacy and autonomy and all of the above. Um, I don't have time to go into basically trauma-informed care for us. Um, that'll be for another day. But we're also secondarily traumatized, and applying some of these principles to us, I think, can also improve our interactions in these cases. But finally, there's not much time left, but I did just want to open up a little bit to the audience. If if anyone wants to share like any tools or strategies, difficult situations they've been in, um, and they've used for, sensitive exams or difficult interviews, what have you. Uh, if not, or if I'm out of time, uh, I will say thank you.
Okay. Um, one point that has come up in geriatric care of of older patients who've had trauma is that even beyond the damage done by the acute trauma, there is actually increased morbidity and mortality down the road. And a lot has to do with affecting the activities of daily living, making them worse. Some has to do with psychological things on older people when they've had trauma. For example, they get afraid of being able to go out in the street anymore. And there have been a few articles recently about this and how older people who have even fallen without bad trauma, like someone assaulting them, really need support going forward. And I think it's something that we don't always think about.
Really great job, Antonio. Incredibly important topic. I think something that you touched on and mentioned, but just a more of a reminder that the ideal is to approach every patient experience with this kind of script. And